Welcome back. We're joined here at the table now by three new panelists, and you have their bios in your packets you've received, but those are Ray Patrick Lake here, Benjamin Wilfond, Vanessa Northington Gamble down at the end. I want to thank all of our speakers in our first session, and do want to say, thank them especially. You will notice that in those talks that the name of that trial, which should not be named, was not spoken once. So we can see if we can keep that string going during the discussion period. What we'll do over about the next hour and 10 minutes or so is we'll have a discussion here among our panelists, including questions or discussion from the audience. We do have some time reserved for public comment time at the end of this, so that will need to happen somewhere around 12:15 or so we'll still be able to make our scheduled lunchtime of 12:30. What I'd like to do to start off the discussion is to ask each of our three new panelists if they have any comments or reactions to the talks we've heard before we open it up to a broader discussion. So I'll invite Ben Wilfond to go first on
that. Thank you. Actually, I think the first comment that I'll make actually relates to Nancy's talk, because it was really very helpful. I think one of the issues for me is the definition of risk, and whether we think of a risk in the context of informed consent as a risk of harm versus information about things that may happen that are important to know about. And so I think that all the things that Nancy described are important for people to know about, but I think it's a question of where we label that in the consent form and how it's described. And I just wouldn't describe all the things that Nancy described as a risk of harm. I was also inspired by hearing Jerry Menikoff's analogy with this motion study, and I'm a cyclist, so I kind of found myself visualizing a study of gym users comparing people using a recumbent bicycle to a upright bicycle for a year in the gym, and where one of the outcomes might be dropout of using the gym, it might be looking at their anaerobic threshold, a variety of things. And I think as I would be talking to them about these issues, I would be describing these things. But I'm not sure I would say that a risk of participation in that trial or a risk of randomization is causing you to drop out or to have an adverse effect on your anaerobic threshold. I would describe these as things that we're trying to learn about, and would describe these as issues of uncertainty, but I wouldn't be describing them of risks of harm of being in the research, in contrast to what they otherwise would have gotten as part of using either the recumbent or the upright bicycle based upon their own preferences.
Thanks. Hi, I'm Ray Patrick Lake, and I am representing the patient perspective. I think we heard a number of thoughtful talks, but I think what sticks out most to me is that perhaps from Nancy's talk again, I really am hoping that we can arrive at some place of practical balance where we can take some of these ideas that are a bit abstract to me and get them into something that's practical and implementable without overburdening research. I do have some concerns that we're coming up with definitions of risks and risks of randomization that really do ignore what's going on in the real world. We know that there's practice variation. I'm the president of a foundation for patients, and if you've ever gotten an email from patients, I actually will tell patients, if you want a full unbiased informed consent, you can see this physician. If you are dead set on getting this treatment, go here, because I know that this provider only does this, and he won't even tell you about these other 3 things that are actually standard of care. So I think we need to take that into account. And I think I'll stop there for now.
Thank you. I want to put this conversation in a broader perspective, because one of the things, even if you look at the first line of the guidance, and to evaluate treatments or procedures that are medically recognized standards of care. And I do work and write about people in this country who are still striving to get those standards of care. So I think that when we have this conversation, we need to recognize that who someone is, be they their color of their skin, where they live, how they are abled, their sexual orientation, leads to differing standards of care. And so that when we, I just want to echo the comment about variations. So there are variations already for people. So when we have a conversation about standards of care, I think that we are fooling ourselves if we do not acknowledge that for a lot of people there are examples of racial and ethnic disparities in health care. And the Institute of Medicine did a great job in 2003 when they did the unequal treatment report. And so that I think that we have to have this as a part of the conversation. And we've spent time talking about study bias. I do work in looking at unconscious bias of health providers. So, so that's a part of this conversation. And then the other thing that is tied into some of the work about racial and ethnic disparities in health is there are people who will go in and see a black patient and say that patient should get a thiazide and not a calcium channel blocker. So we need to figure out what that is about so that, and so if we do studies on looking at this, how do we randomize people? And then we also have to think about some of the group harms that there might be when we start looking at some of these racial issues in healthcare in terms of reifying race. Clinical myopia. If you see a black person walk in, it's like, oh, that's the person who's going to get the thiazide. The other thing in terms of communications, and I think we got to it at the end when Miriam was talking about the woman in West Virginia. And I said, oh, it's religion. That it's not just about language, it's about culture. And as the United States gets more and more diverse, it's not just going to be about language. It's going to be how different groups perceive words as random, flipping the coin. And so I think that we need more talk about that. But also, one of the things that I have been doing more and more, and it's been a learning experience for me, and sometimes not always an easy learning experience, is working with communities and asking them. And so those are some of the things I just want to put out on the table.
Thanks. To open up our discussion, what I'd like to do is to start with this concept that Susan introduced, so maybe I'll ask her to speak a little more about this first, this idea of equipoise. And the question that I wrote down as she was saying that, and I see many of you in the audience are old enough to get the bad 1970s pop music reference. Does equipoise mean does anybody know which treatment is better, or does it mean does anybody care? Is equipoise about evidence? Does equipoise mean about evidence, or does equipoise mean about preferences? Is it equipoise if people have a preference even if the evidence says they're equally good? Or what is the real definition of that equipoise concept?
Well, I think others at this table might be better suited to answer that. I have not. It's been a long time since I've read these papers that I mentioned. But equipoise, I think, from an individual perspective, is whether the physician feels that there's no reason to prefer one treatment or the other for an individual patient. Whether so it's based on a belief. It's not based on whether the physician is fully informed or how much they know. It's based on what the physician believes, because this is given as the ethical basis. Can the physician do this or that? So that's what I think. That's what I think it means.
Well, I'll just follow up. I mean, Susan, I loved your slide because you went from equipoise to clinical equipoise to uncertainty, and your last point was that uncertainty is really the underlying issue that really does drive clinical research, less than equipoise.
I found myself wondering whether a patient needs to be in equipoise or wants to be in equipoise before consenting to be randomized, or is that an obvious standard or one that's really too high?
Well, I think that's the bottom line of what's called the uncertainty principle. That is, both the patient and physician have to be uncertain as to whether either of these treatments would be a good treatment or which would be preferable. So I think it can be both, but to me these concepts have always seemed very blurry to me, because if you may have a preference, but you know that other people have a different preference, I don't see how, unless you're an extremely, super high-powered, confident person, how knowing that a lot of other smart people think something different can't, lead to uncertainty. So I think there's a blurring of the concepts.
Just want to point out that there's preference saying, I like that drug better than this drug. And there's preference based upon the outcome states that might occur with the two treatments and how they feel about those outcome states. And a really careful dissection of preference would get the physician involved in describing those outcome states and talking to the patient about how they feel about them.
On that topic of randomization altering risk, Nancy said not necessarily increase, but does alter. I'd be interested in some more talk about alter in what way, and maybe focus a little on, I guess, the idea of alter in a predictable or in an unpredictable way. The idea that does it matter whether assignment of treatment, random assignment or some other systematic assignment, affects our average expectation of outcomes? Or does it matter, even if it doesn't affect the average expectation, that it affects the outcome of an individual? And does it matter whether that's even knowable or knowable in advance? What's our standard there of is the risk standard average expectation, individual expectation in a knowable way, individual expectation in a completely unknowable way?
Well, I'll take a crack at that.
We'll get some comments on this one, I think.
Yeah. So, to me, the biggest obvious problem with randomization is that you give up choice. And that, in general, I think, as we talked about in the previous discussion, will involve the patient's feelings about the outcomes that they face and so forth. And I continue to wonder, and I think it'll be a matter for empiricism, about how important it is to give up choice after a full explanation of harms and benefits, and whether ultimately that's an individual choice, but it would be important to know how that compares with all of the other factors that are involved in making a decision. And I'm guessing, based on the analysis that I did, that the harms of giving up choice are pretty small compared with the harms of regular care, especially with doctors who have preconceived routines that they like to stick with.
Well, and let me follow up on that a little bit, because I think on the one hand that talking about average risk, or I don't really quite understand that as a notion. It seems to me that it makes more sense to talk about, and in a way what I was really talking about in my presentation was how you convey the experience of being in research to a potential subject. And that, when it includes randomization, it includes the possibility that you will get that you yourself will get something different than you would get if you were not on study. It also includes the certainty that there are aspects of the experience that you will have that will be quite different from the experience that you would have in getting even the same intervention if you were not on study. But all of this is against a backdrop of a lot of misconceptions about what happens in ordinary clinical encounters. Everybody seems to believe, you revert to the notion that, well, even though I'm being randomized, somehow this is going to be what's best for me, because that's what people believe about their encounters with their physicians. And there are good reasons for that, because it's necessary to establish a trust relationship with your physician. And not many physicians are practiced in saying, I'm not sure what the answer is here, but still engendering trust. So the contrast there's an artificially enhanced contrast between the research setting and the clinical practice setting, I think, that we're kind of uncovering by asking some of these questions.
One question is whether not just the process of randomization, but properly conducted research in some sense counteracts at least some aspects of implicit bias.
Well, yeah, and again, it's very, very dependent on the particular situation that's being addressed. But, and there are very many good clinicians who do explain alternatives, do their best to do individualized care, and do build relationships of trust. But as has already been pointed out, that's not something that is accessible to a lot of folks. And so being very assiduous about that on the research side really, to my mind, leaves a big gap on the clinical side.
So how do we marry the two things that you just said, Nancy? I mean, I think we know that there are gaps. We know that care and consent and care is actually lacking. And I think there's this fallacy that patients aren't already, that they haven't given anything up yet, and that by being randomized, you're giving something up, when the truth is, depending on whose door you knock on or what coverage you have, what your physician prefers, oftentimes there really isn't autonomy and patient preference and all these things that in ideals we think are fabulous. But in practice, I think we do have to recognize that patients have thousands and thousands of questions that are important that need to be answered, and what's the risk of not having them answered? And somehow we need to come up with a framework and a trade-off of, you know, what are we willing to say that it's okay for patients to give up in certain circumstances by being randomized. I personally am a fan of the Kim and Miller model for pragmatic trials for integrated informed consent, where it does start with practice and that encounter, and we're not starting with not consenting patients in any way. We're sharing information that was reasonably shared in practice, and then we're describing the risks of research. And I think that is something that we really need to look at.
You know, I think there's a distinction between saying that randomization matters to patients and we want to figure out how to communicate about that versus communicating it as a risk. I think, and a risk of harm. I think that's the distinction that I think is very important that we don't fall into. And that's my concern with the regulations, that it labels randomization as a risk of harm rather than something that's just maybe important.
Oh, I'm hitting the wrong button. Okay. So we've gotten a little bit off, but I just wanted to bring up, is sort of in part along the same theme that Vanessa brought up. So in one of the papers, and I can't remember which, I read a lot of papers over the last couple of days on this topic, among, again, religious participants, there was actually a greater acceptance of randomization because there's still innate belief is that whatever treatment they would be randomized would be kind of God's will. So it's just an interesting twist on the view of randomization.
Well, that brings up the importance of appealing to a patient's sense of altruism, and I wonder whether we perhaps should make more of that. That there's a positive utility for many people to feel like they're doing things for other people.
I want to go back to Steve's point about implicit bias in randomization. I hadn't thought about it that way, but then now I'm going to sound like Nancy. It depends. It depends on at what stage, who's doing it, but it's a way, I think, of thinking about it. But I think it would depend on the stage and what's the particular purpose of the study. And so but I think that's a point that we could, talk some more about. But I want to get also back to Nancy, your point about, and I think it ties into some of what Ben brought up, but you talk about conveying the experience of being in the trial. That's an important point. But at the same time, I think is even more difficult is to figure out how that's interpreted. Is it interpreted as a risk? Is it interpreted as, well, this is what it's supposed to be like? is it interpreted like, this is a good thing to do? So there's also, it's the conveying the experience and then the interpretation. And which is, it's also like risk. Somebody might say a 5% risk might be, oh, that's a lot, and someone else might, oh, that's nothing. So it's just, how groups of people interpret those different things.
Well, I mean, we could get really, really deep in the weeds because of the many different it depenses that come up in just trying to respond to what you say. But I guess there are a couple of really big things that come up in terms of attempting to convey the experience of being in research. I mean, I've heard people who were desirable potential subjects say that that somebody attempted to recruit them into a trial by talking about how much individualized attention that they would get that they wouldn't get from their own doctor. Which is probably true in some respects, and an indictment of what happens if it is really true and significant. It's indictment of what happens in the clinical relationship. I've also heard people being recruited into trials with the perception that this was their treatment, and then long-term follow-up falls apart because people figure after I've gotten the intervention, I don't need to keep coming back for these study visits. So that's a failure to say altruism is actually part of what you're doing because you're making a certain kind of a contribution. Your relationship to the clinical investigator is, in at least some important respects, a different relationship from your relationship with your physician, and that matters. There are also, just one other point, because I want to go back to, I think it was John's question to Miriam about what if somebody doesn't understand randomization, shouldn't we give them a test? And there's two ways to responding to somebody failing the test, which is you don't get to be in the study, or the other response, which was actually used in the sham knee surgery trial that the VA did a while back. If they flunked the test, when we're not able to explain randomization, it was explained to the potential subjects as, well, this is the investigator's fault because he didn't explain this well enough to you, so we're going to get him back in here to explain it to you again so that he can get it right. It's not that you got it wrong, it's the investigator didn't get it right. And that's a perspective shift that's really important.
And Nancy, I just would like to add a third in terms of, you were saying the two things that you've heard. And I would add a third that I would hear for certain people saying this is an experiment, and which has a totally different meaning for certain groups of folks.
So on this idea of how we talk about random assignment, the coin flip analogy, comes up a lot, like flipping a coin. As we were talking about that this morning, I was thinking, where else in the world do we flip coins? I mean, we flip coins before sports contests, we flip coins to decide tied elections. Most of the time we flip coins, there is a known desired outcome. There's something two people want, and we flip a coin to decide who gets it. So it may not be the best analogy here. Because it may be conveying that behind all this secret consent form here, one of these is better, and we're going to decide if you get it or not. How would we talk about this? Where is the other place where we deal with this uncertainty? Because it's an odd thing evolutionary-wise, this thing we're asking people to do is an odd thing to ask people's brains to accept.
Just as a really quick counter or alternative example to the coin flip, and David Magnus and I will be describing this later when we talk about the project that we've been doing for the last year, looking at patient attitudes about this sort of research. But we use the metaphor of a gumball machine rather than of a coin flip, putting a quarter in the gumball machine and a gumball comes out, but you don't know what color it's going to be. So that's another way that we've tried to convey the idea of randomization.
Did you say gumball machine?
Gumball machine, yes.
That you have to be a certain age to get that one. So so that's what I would just say about that one.
But in fact, there are lots of different ways to talk about randomization and other research concepts that are sort of culturally and generationally specific. You just have to work harder to get to them. I mean, you could say, close your eyes, reach into the jar of M&Ms, pull out an M&M, I know there has been some work, Family Health International and Research Triangle Park did some work on explaining concepts like randomization to study populations in sub-Saharan Africa that were based on different kinds of farming and cooking analogies. So it's possible to do, it takes time. And one of the problems that underlies everything that we're talking about is the amount of time it takes to actually talk to patients in the physician-patient relationship or potential subjects in investigation in a relationship with a clinical investigator. You know, time is money, and we're talking about fixes that are going to take more time and therefore more money, and you know, there's a lot of resistance to that.
That's why I brought up the point of, you know, trying to ask particular communities and diverse communities for the language. There might be ways of getting, you know, a better grasp of what the concept is. And one of the things that we haven't talked about at all is that some of this research is going to be done in an international context. Mm-hmm. So that we need to, to figure, that out. And I like Gumball Machine. It was one of the best things of my life, going to the store and, getting it. But especially because my mother wouldn't let us chew gum, so it was really like doing something illegal. But I think if we figure, that's one of the things to figure out from different communities, different groups, what the language could be to help us with this.
I'd like to get back just for a second to Nancy's remark about time is money. And a lot of the conversation we've been having in the last few minutes has been about researchers building trust with patients without competing with their doctor. And I think I'm beginning to see that may be a potentially a protracted process before a patient's willing to basically trust the researchers to look after their interests. And that funders are perhaps going to have to recognize that, and a lot more in the budget to get informed consent in a way that keeps patients in research.
So I actually keep going back to the comment I think that you made, Hal, and what's your name? Sorry? Ray. Made, which is, again, all these things that, the patient doesn't understand, that the provider just is used to doing things a certain way, and may or may not have actually read the evidence on it, but heard from one professor that was the way to do it, or from a colleague or a drug rep, and it could be that the insurance company is not going to pay for it. And so someone here, I can't remember who it was, said, well, maybe randomization is almost a little bit protective, right? Which I have to say, that rang a little true for me. I would rather, if the evidence is murky, I feel more comfortable with a randomization assignment than a physician just saying, well, in my patients this, because that's just their experience. So, getting back to informed consent about randomization, it does also just make me wonder if more explanation needs to happen about that. It's not randomness, but the things that happen in usual care that makes randomization not seem so bad, or maybe even an improvement.
Yeah, I'd like to follow up on that. I think what we would think of as the ideal in usual care outside of a study is that if there is a choice, the physician, this is apropos of your shared decision making, the physician will say to the patient, this is the condition that you have, and these are the options, and this one is, maybe more apt to do this one maybe more of a pain in the neck, but maybe it has a little less of this. You know, you go through all of those things. That's what I would like my physician to do if I have to develop a new, you know, if I have a new treatment for a new condition that I have developed. Now, we can all say and believe that lots of physicians don't do that. They will do just what you say. This is the way I always do it. This is what I learned. I haven't read a medical journal in the last 10 years.
They won't say that.
They won't say those things. They'll just say this is what you get for this treatment. But it seems to me that if we're doing a study, then, you know, our sort of goal should be that the patients should know what our ideal physician would be telling them when they were making a decision. I think part of the agonies that we've gotten ourselves into is because informed consent, the way it's done now in most studies, I think we all recognize that it's unsatisfactory. There's been almost every study has shown that people don't understand. The consent forms are, 20 pages long, and no matter what you say about, how they should be, readable by somebody with a 5th grade reading level, they're not. So, there's a reaction against doing this kind of informed consent, obviously, in the kinds of, in the kinds of studies that we're talking about now. But I think what we really want is all informed consents, not just those in standard of care studies, to be ones that are more simulating what a reasonable, informed physician would do in regular practice.
I think that's a great place for me to jump in. Okay, so this all sounds really good, but patients have a lot of questions that we want answered, and we want them answered in a timely manner. And I think we have to look at the practical nature, and if we're going to do some of these large pragmatic trials that have very diverse populations, I would love to sit down with each patient community. I agree that they can provide amazing insight about what their needs are, but if we're not going to be able to develop individualized informed consents that speak to every flavor of everything and every cultural aspect, I think we're going to have to come up with something practical. And I think this is where the patient community can be of use. Just bear with me for 1 second. This seems like it's in the forest, but a few years ago I was fresh out of a clinical trial. I participated in a workshop on IND safety reporting. At the end of that workshop, I was asked, what are your expectations of a patient? How would you like to learn about adverse events? I said I want to know about every single adverse event in that trial in real time. Guess what? I later learned that actually really isn't practical, and in fact, it would place such a burden on research, and those reports would be uninterpretable. So as a patient, I had to move to this place where I said, you know what, I'm willing to wait and willing to accept this level of risk, and I feel like this is what we need to do with this informed consent conversation. It would be great to tell every patient everything in real time and that every physician is going to be great at this, but we know that's not what's going to happen. So I just implore us to come back to something that's practical, that doesn't have researchers that are smart folks running away from research and saying, I can't participate in this. I've got a 15-minute visit. I'd love to have my patients in this study, but I can't reach this level. So hopefully we can find something that's more balanced.
You were asked the question at the end of the study. You were asked that. A lot of people aren't even asked the questions. And so you were asked the question and then was able to say, well, now I understand a bit more. And so in terms of, so you changed your attitude, after. But there are a lot of times where people aren't even asked the question and don't have the opportunity. And, in certain diverse communities, of course we can't have everything on an informed consent form. But we do have to make sure that we respect people and communities in a way that they are asked, can give input, and then we might change. So that's what I think is something I think is very critical.
The literature on decision aids for patients is quite large. There have been over 100 randomized trials of decision aids, which are basically packages of information on a video disc or on the internet. And they have effects on patients' decision conflict, satisfaction with the treatment chosen, and in many cases, decisions to pursue more conservative treatment, at least for a while. So I'm asking the question of the researchers: to what degree have decision aids of this type been used to inform patients who are considering being in a trial?
To coin a phrase, how you're referring to the decision aid literature makes me think what we're talking about in consent forms really are indecision aids. Because we're as opposed to saying we want to make people more certain of a decision when things are uncertain, what we're saying is we'd like people to be willing to move into a position of uncertainty and accept uncertainty. I think that an informed consent decision aid might be different from a treatment decision aid, or do you see a difference there?
Well, I'm not sure. I think in both cases, the intent is to inform the patient about risks, harms, potential outcome states, and so forth. And maybe we want them to be in a state of indecision, but the reality is that the tool we're going to use is going to be the same, regardless.
Yeah.
Oh, sorry.
Right.
I just want to say, as one of those people who makes decision aids, does huge randomized trials in very diverse populations, we actually just published one a couple months ago in JAMA, I just want to clarify that the decision aid could still be used because it's the decision aid for a decision to enroll in a clinical trial. So that's your certainty would be diminished. Uncertainty, by using this aid. That's the way I would frame it.
But in these decision aids, how do they differ from how does an indecision aid made for the purpose of helping people decide about being in a trial differ from one that's aimed at trying to help people make a decision in a close call situation? How are they different?
Well, I guess I'm saying I don't think it is that different because it's a decision whether or not to enroll in a study. Enrolling in a study has potential harms and benefits, as we've talked about, and this is just to help you understand what's entailed, understand randomization, and now that you know these things, you can make a more informed decision as to whether you want to sign up.
So it might be partly about the clinical content and the downstream events, but it would include other things that were specific to the trial, like follow-up and so forth.
Oh, yeah, absolutely. And I just would say one more word about decision aids is I think that the decision aids are created to emulate sort of that ideal physician encounter when the options are all presented in an unbiased fashion with the evidence and so forth to help patients, work with their physicians in getting a better understanding of what the right treatment course might be for them.
What were the results of your study? Did it, the decision
Yeah,
aid?
actually, so it was interesting. Not only it did, increase knowledge and well, actually, by the time we measured decisional conflict, it was low in both groups. But it did also make more. It was for pregnant women, and fewer women opted to have any kind of prenatal genetic testing and altogether. So there were more people who had no testing as a result of seeing this, and there was also a sharp decrease in the use of invasive diagnostic testing. I can send you the paper.
I have a question, and it has to do with the purpose why we are here today. And it is, how does all this have to do with standard of care research, and is it different? Because many of the things that we've been talking about has to do with clinical research. So what is it about standard of care research? I mean, I see, in terms of talking with patients, I could see, participants, I could see someone saying, well, there's already a drug out there and it works. So why do we need to do this? Well, is it because this drug is cheaper? And there might be one that's a bit more expensive, but it might work a little more. So, and I'm in a hospital where the standard of care might not look too good. So how do we do those discussions about, standard of care? So I just want, because I'm just struggling about the differences here and what we can get out of a discussion about standard of care. So I'm just going to put that out there.
We should come back to that, but I think Ben wanted to make a point about the earlier discussion.
And I'll make the earlier comment, then I'll come back to the standard of care question. My earlier comment regarding decision aids is that, I think even outside of formal decision aids, there's ways that we can use the underlying concept of decision aids, which have to do with allowing patients to make choices based upon their preferences and values. And as an example of that, currently I'm the co-PI of a clinical trial using genome sequencing for for carrier testing and for reproductive decision making. And as part of that project, we, as part of our consent form, at the end it says, here are 3 reasons you may want to participate, and here are 3 reasons you may not want to participate. And I do that not only in research, but even in clinical practice. You can give people 1 or 2 to 3 reasons on either side, and that allows them to choose where they fit in. So I think that's how I personally approach that question. And of course now, well, it was by talking with well, actually in that case it had to do with we did focus groups. And listening to focus groups and hearing what people's thoughts and concerns were in various ways, and that's how we sort of pulled those together. So I think, and that gets to another issue that I was going to bring up before. For the last year we've been doing focus groups about the standard of care research, or which we call research and medical practices, and people, it does take some time to explain it, but not a whole lot of time. This question of how long does it explain to talk about research and why we want to do this study when we're not sure what's going on. It may take a minute or 2. It doesn't take 20 minutes. And we found that for many patients of focus groups, an explanation about, we really don't know which of the best is, I'm not sure which to do. And because of that, what I like to do is to assign you by chance to one of these 2 drugs, and that way we'll learn more over time which is better, actually resonated with people when it was explained that way by their doctor.
The question about what do we mean by standard of care research, and somebody saying, what do you mean you don't know which one of these is better already? Sometimes that's the case, although I think it'd be worth hearing from people about this. The big research questions of the next 20 years will likely be subgroup questions. They'll be about personalized medicine, not about average effects. So I don't think the ACE inhibitor atenolol question, that we're not likely to discover a big main effect there that's so far undiscovered by previous research. But still the question is for whom? Or as Pecori would put it, for someone like me. It's going to take pretty large studies comparing current standards of care to answer those questions for people. That concept is a difficult one to get across in terms of, well, why are we doing this study? And the outcome at the end of this study would be the treatments, we would say these treatments at this point are in a dead heat. They're tied. It's too close to call, as Hal said a few minutes ago. And at the end of this study, what we expect the main outcome to be is they're still too close to call. But maybe we would learn something that would be useful to you or people like you.
Yeah, I think certainly the large pragmatic trials of treatments that are basically pretty in equipoise, and you're basically hoping to be able to identify characteristics of patients who respond better to A than B, and characteristics of patients that respond better to B than A. And of course the challenge is that means subgroup analyses, which means enormous patient populations in order to do it. So although you often will size a study to detect a difference between 2 closely matched options, what you're really hoping to do is to size it to get some useful information that you can act upon rather than simply establish hypotheses to be tested in another trial about patient-specific information about treatment response.
I was just going to give a real-world example of why we would do this research is because it matters to patients. So congestive heart failure patients, they're all on diuretics, but they would like to urinate less. So maybe they have the same clinical effects, but patients really do care about some of the properties of these different drugs.
I want to come. I've been thinking about Vanessa's question, and I think I have a partial answer to how is standard of this, or research and medical practices, I'll use that term because I like that better than standard of care research, but how is research and medical practice research different from other types of research for new drugs? I think the difference has to do with the context in which it's occurring, in the context of research and medical practices, without that research, they would still be undergoing those same medical practices or a variation of them. And so what's happening when we're doing research on that is we're taking people who are already going to be experiencing those same activities and then studying it more carefully, just like my example of the gym users on the bicycles. Randomizing people to the 2 different bicycles doesn't necessarily, we may learn about which is a better bike to use, but these are people who otherwise would be using bicycles. And so in that regard, I don't think that that why we want to describe that to people and why we're doing it, I'm not sure I would say that at the end we're harming people by randomizing them versus just letting them use which bicycle they choose.
I think, to get back to Greg's point about subgroup analysis, I think you're absolutely right about subgroup analysis, but I think part of the tensions and concerns about how do you divide and develop those subgroups. So, I mean, I think many times we reflectively put people into racial categories, which might, including somebody whose parents who came into the United States enslaved to a recent African immigrant. In America, they are all put in the same box. And there's some problems with that, which we don't have time to go through today. But so that there's some issues around the subgroup analysis, and I think that the fiasco around BIDIL shows what some of those were. In terms of this, it was for those of you who aren't up on the BIDIL literature, it was a drug that the FDA approved in 2005 for self-identified African Americans. So the question is, should Tiger Woods get BIDIL? No, because he's not a self-identified black person. But Barack Obama is. But there were some problems with that, including clinical myopia. It's like, well, this is the drug for black people. I have a colleague at GW and talked to a patient about that. He says, no, give me the drug you give the white people. I think probably is the better drug. And then the other thing about reifying race as a biological construct. So there are questions and tensions about how we also do our subgroup analysis, which will become, I think, an issue in, Ben, I do like the word research of medical practice, especially when you think there are physicians and how when you had the little house with the doctor, treating high blood pressure, I had another box and a house, and that is a black patient walks in and someone thinks, oh, I know thiazides are better for them. And so that these are some, in terms of looking at some of this research that I think we have to be aware of, and then talk about how do you randomize in terms of these subgroups.
It used to be, oh, sorry.
I was going to ask, but go ahead. I was going to ask a follow-up question, but.
Well, it's on the same
Yeah.
topic. So
Okay,
it
yeah.
used to be conventional wisdom among clinical trialists that the best treatment overall was likely to be the best treatment for anybody in any individual subgroup. And there was a lot of discussion about that because people can get very misled by looking at a variety of subgroups, and we've seen this over and over, where you do one study and it looks like this is the subgroup that's getting all the benefit, and then there's another study that shows something entirely different. There's a lot of chance factors, more than many people appreciate, in looking at subgroups. So now, with this shift toward more of a focus on personalized medicine, there's a renewed enthusiasm about finding out what works in subgroups. I think much of it is driven by our ability to understand genetics, and especially what's going on in cancer, where you can identify characteristics of the tumor. But I think we're very far away right now from being able to look at subgroups in a variety of diseases and be able to say, which one is best. I think we can get very distracted by trying to do that.
So I think that's really important. Genetics, appearance of skin color is not a very good proxy for genetic risk factors, but ultimately cancer, if you're just looking at somatic mutations, isn't going to be a good stand-in for all of the environmental and experiential exposures that people have. We have a long way to go in personalizing most of medicine. But I was going to come back to the issue about just a follow-up question with an experience I had about 15 years ago. So, or actually two experiences. One was I commissioned, maybe it's almost 20 years ago, a large pragmatic trial of antipsychotic drugs. And there was enormous pressure from patient groups not to include one of the first-generation drugs as a comparator, because the assumption was that the second-generation drugs would be so far superior that it would be an unethical lack of equipoise. And then, of course, it turned out that in terms of efficacy, the first-generation drug was just as good, and all you were doing was trading side effects. And it was sort of important in retrospect. But I guess, so the question really is, goes to how we even frame, I guess it's up to individual investigators, but how we even frame these comparative effectiveness research or standard of care questions. Do we do it around which is the population that's most likely to benefit, or at this stage of knowledge, how do we decide which interventions to compare? And I've been thinking about this, also looking at the, coming back to the three humps in the trial that will not be named. I mean, how do you know that again, the central, that people are hoping for Goldilocks, but maybe they're optimizing for negative effects by choosing the middle option? So how do we, I mean, part of doing this ethically is even figuring out how to formulate the right questions.
I want to go back to the subgroups. I don't think looking at subgroups is a distraction, and I'll tell you why. If you look as a group at infant mortality in Hispanics, Latinos, whatever word you want to use, you have one. You can say, well, it's not that bad. It's, but then if you look at subgroups. If you look at Cubanos next to Puerto Ricans, next to Dominicans, you get a totally different story. And so a lot of times these groups have, so you have somebody who is an Afro-Cubano put in the same category as somebody who, this happens in the United States, Brazil, and that's not even, Hispanic. And so that I think that it's not a distraction in terms of trying to figure out, especially in disparity, racial and ethnic disparities research, it's not a distraction at all, because we're trying to figure out how it's affecting particular groups. And it happens with Asians in terms of having this broad category. So I think, and I just want to put on the table that I don't think it's a distraction.
I wanted to come back to the point that Nancy made about, maybe the big issue here is better consent in everyday practice, and got me thinking about it. And we think about consent forms for these sort of standard of care or comparative effectiveness or pragmatic trials. The tradition of a consent form certainly would be to tell you about the potential benefits and harms of the experimental or the study treatments. If you were in this study, you'd have a 50% chance of getting treatment A, and here's what we know about treatment A. And if you would have a 50% chance of getting treatment B, and here's what we know about treatment B. What if we said you should also say what would happen to you if you weren't in this study? And what treatment would you get then? And what would we even say? Would we say, and if you chose not to be in this study, your doctor would likely give you the drug from the last pharmaceutical sales representative who visited, or, the doctor would choose this based on his own usual habits. It's, first of all, what would be the truth, and could we even express it?
Well, in the world of electronic medical records, you actually could have a doctor-specific form that could say your chances are 90% of getting drug B and 10% of getting drug A if you don't participate in the study, because that's what your doctor does.
Well, and, there is, of course, supposed to be a discussion of alternatives in every consent form, and it's usually very short, and, a lot of times it even says, well, your doctor will tell you what you might get if you weren't on the study.
Usually it sort of says, it's up to you.
But I want to go back to Steve's question about, well, so how would we formulate the question in the right sort of way? And I think the underlying question has to be, why are we asking this question? And that relates to, the fact that there are different domains of research, that, asking a question about health disparities research is different from asking a question about a new biotechnological intervention or something. But if the why question is driven by ultimately figuring out how to improve patient care, then that ought to point the way to how to do it. But the why question is affected by so many different things, like what are you most likely to get funding for? If you've had a series of R01s in one direction, you're going to keep having a series of R01s in that direction, and it's driven by what funding is available for. So there are a lot of anomalous pressures in the research situation, a whole different set of pressures in the clinical situation. But if investigators can't always get back to, am I really asking this question for a good reason, then we're not going to get anywhere.
I think we should also be asking what happens if we don't ask this question. Something that Ben said a little earlier, it made me think, what if we told patients, you're being experimented on every day, because we really don't know. And if we started the conversation there, I think this thing would flip. But I know that there are a lot of physicians that don't want to do that. But I really think we need to think of these things. And then also, Steve, what you were saying about, the early generation drug was the best. Aside from these side effects. Well, equivalent. But patients really do care about these side effects.
It's in our next sort of 20 minutes or so, like to sort of move on to maybe even more specific, try to bring this discussion back to the draft OHRP guidance, and what, if anything, would we say about that? And one, maybe this is a specific point only of interest to me, but I think it may be of some broader interest, and focused on the issue of random assignment. In the Federal Register notice that accompanied the OHRP guidance, there was a discussion about this specific question of what would this mean about waiver of consent in studies that randomly assign treatments, and the response from OHRP to that question was not very specific. There was a sort of specific point put out there that waiver of consent should still be allowed as long as the criteria were otherwise met, but not a very specific response. So I'd be interested in some thoughts about that specific question, about waiver of consent, the definition of minimal risk. If we say random assignment alters risk, how does that interact with the concept of minimal and the criteria for waiver?
I'll start, and then people can then criticize me or challenge me. I think that the issue with the OHRP, I don't know what OHRP was thinking, but I think they were sympathetic appropriately to Nancy's observation that there's a lot of things that matter that we should talk to people about when we do research. And I think what they chose to categorize those as risks of harm, because that's the definition of risk in the regulations. I think that they may matter, they may be important, but they're not risks of harm. And the problem with that is precisely the issue of waiver of consent, because we can't waive consent unless it's minimal risk. I also think it's important to be very clear that waiver of consent or waiver of documentation of consent says nothing about our ethical obligations to talk to people and engage people. So when we talk about waiving consent, it doesn't mean, it's very similar to the Kim Miller proposal. It means talking to people, having a conversation. One of the things that we learned in our focus groups and our survey, which we'll describe later, is that people want their doctor to talk to them and ask for permission, whether it's medical record review or randomization. They want to have a conversation. But having a consent form, even from patients' views, isn't necessarily helping with that conversation and with their decision.